Mbak Afri.
Nampak?
Yang semua dah ready dah. Semua dah ready.
Dah, doktor.
Mana ni? Internet unstable. Sekejap. Siapa present dulu? Muhammad Zulfaqar.
Ya, saya doktor.
Ya, grup mana?
Ha? Sorry, doktor apa?
Muhammad Zulfaqar.
Ya.
Present.
Okey.
Berapa bulan lagi?
8.
Fine.
Ya. Okay, Assalamualaikum warahmatullahi wabarakatuh. Today I'm going to present about bronchial asthma. My name is Muhammad Zulfaqar bin Azurin. My metric number is 1813681. So in this presentation, I will present to all of you the definition until the management of the bronchial asthma. So firstly, we proceed to definition. What is meant by asthma? According to Respiratory Protocol 4th edition, asthma is a chronic airway inflammation that lead to increased airway responsiveness that cause recurrent episodes of wheezing, breathlessness, chest tightness, and coughing, particularly at night or early morning. So we must remember these 4 key features, which are recurrent episodes of wheezing, breathlessness or dyspnea, chest tightness, and coughing. So we proceed to the epidemiology. Okay, asthma is the most common chronic respiratory disorder in childhood. The prevalence of asthma seems to be plateaued in Malaysia with 5.6%, 5.8% of children aged from 6 to 7 years, and about 8 to 8.9% of children aged between 13 to 14 years. This epidemiology is made in Malaysia, and their prevalence is higher among urban and inner city children. For example, we can see that 7.3% in Muar, while 13.9% in KL. The responsible for asthma is also responsible for 10 to 20% of acute admission in children between age of 1 to 16 years old. Okay, we proceed to types and etiologies. There are 2 types of asthma, extrinsic and intrinsic. In this, I think this is the best table that I can find. Usually, the extrinsic is related to atopy, meaning that it is related to immune response. It commonly affects children, while the intrinsic factor is not related to immune response. It is common in adults.
Huh? It's complicated. Tak payah.
Okay.
Usually, practice kita tak pakai this one.
Sorry, Doctor?
We don't use much of this lah. Complicated lah.
Okay.
Extrinsic dan intrinsic yang most of us dah tak pakai dah.
Oh.
Nah, tak pakai. That one is usually non-pulmonologist. Most pulmonologists tak pakai dah. Asthma is asthma.
Okay.
So skip. Adult mungkin pakai, pediatric tak pakai.
Oh,
skip.
Okay. Okay. Next, for the pathophysiology.
This one better.
Okay. For the pathophysiology, first, the patient need to have a trigger factor. The trigger factors can be a lot of things. For example, most common in children is environmental factors such as allergen. The patient may allergic to some substances like pollen, peanut, and so on. However, there are also genetic predisposing factor. For example, if the patient parents had previous conditions such as eczema that related to immune response, the patient can also have the trigger factor. So the trigger factor will lead to three things. We need to remember it will increase the mucus production. It will also lead to the airway muscle tightness, and it will cause mucosal edema in the bronchial membrane. So the effects of these three things will cause narrow breathing of passage that cause wheezing, cough, and dyspnea. Next, uh, this is the um, immunologic response that caused by the triggering factor. As you can see, the allergen will firstly, the allergen will be taken by the dendritic cell. It will present to the CD4 T cell. CD4 T cell, as we know, it works as T helper cell. It will secrete some chemokines such as interleukin 4, interleukin 5, and interleukin 13 to plasma cells. The plasma cells um, will release IgE, and the IgE later on, if there is another allergen in the body, um, it will warn the muscle, and muscle will secrete the histamine, leukotriene, and phospholipid, prostaglandin, sorry. Wait a minute. Besides that, the interleukin 4 will also stimulate the eosinophils to secrete the cytokines. Okay, next, we proceed to clinical features. Symptoms. As we can see in the definition, asthma is characterized by coughing, wheezing, chest tightness, and shortness of breath or dyspnea. Uh, it is a recurring episode following symptoms such as wheezing, coughing, and dyspnea, usually participated by allergen exposure or viral infection or exercise. There are also some patients that got their asthma attack after being exercised. Okay. Okay. Sometimes we can see the presence of atopy such as eczema, allergic rhinitis, or conjunctivitis in the children or the family to support the diagnosis of asthma. We can also ask about the patient previous experience with asthma medication. So we proceed to the signs. Okay, these are the things that we need to see to look in the if the patient come to us. First one, for the inspection. Most of the time, the patient looks normal. However, the patient can also have altered consciousness, signs of respiratory distress if the asthma attack is asthma attack is um, severe or bad. The patient can also be sinus because reduce of oxygen. And then the patient, in some cases, they might have dry skin or eczema, and they can also have Cushing features, hyperinflated chest, and Harrison sulcus. On the palpation, we can see that the patient might have decrease in chest movement and also decrease in vocal parameters. The percussion, uh, there will be hyperresonance to percussion because usually our lung is filled by air. However, if there is lack of air, the resonance can be heard significantly. That's lead to the hyperresonance. During the auscultation, we can hear that diminish of AN3, vascular breathing with prolonged respiratory phase, like that. The patient can also generalize respiratory rhonchi, crepitation, especially in infant. And we can also hear that silent chest. We can also, silent. We cannot hear anything, sorry. Okay, so next, these are some pictures uh, for asthma. So we can see the nostril, flat nostril, and some of the signs of respiratory distress. I hope you can see that the patient has frightened look, pale skin. Okay, and then there is the picture of Harrison sulcus. And then we can see in some patients they might have eczema. So for the differential diagnosis, we can classify it according to the causes. For example, upper airway disease, we can have allergic rhinitis, sinusitis, vocal cord dysfunction, obstruction of large airways, and then obstruction of small airways, and other causes. You can see there is a lot of differential diagnosis. Next. So to investigate, to confirm our diagnosis, first we need to do lung function tests, which are spirometry and peak flow meter. The response to the bronchodilator therapy is improvement in peak expiratory flow. We can see there is more than 20% or forced expiratory volume in 1 second. More than 12% is supportive of asthma diagnosis, meaning that first, when we ask the patient to do that, we can see the lung function test is reduced. However, when we introduce the bronchodilator, we can see some improvement. And then we can also measure exhale nitric oxide, which can increase value of nitric oxide. And then we can also do skin prick test to aero elegant. If the patient is immune mediated, we can see positive prick test. Next. So we can also do imaging studies such as chest X-ray to look if for other causes, for example, mediastinal mass or pneumothorax. Okay, next. HRC Hasana disease. Okay. We can also do other investigations to look for other differential diagnosis, such as HRCT, thorax scan, 24-hour pH study, immune function test, and so on and so forth. Okay, next, management. So for the management, firstly, we need to evaluate the patient condition. We can we need to classify the patient if the patient has intermittent asthma or persistent asthma. There are some criteria that I took from the CPG Malaysia clinic. Okay. So as you can see, for intermittent asthma, the patient has daytime symptoms less than once per week, nocturnal symptoms is less than twice a month, and so on. But the persistent asthma, we can characterize it by mild, moderate. We can characterize it to mild, moderate, and severe. There are the characteristics. For the drug therapy, next. Okay, for the drug therapy, all asthma regardless the intermittent or persistent one, all of them need reliever therapy. For the reliever therapy, we will give the intermittent short-acting beta agonist, SABA, such as salbutamol or terbutaline. It will improve the respiratory symptoms associated with acute asthma event. However, in the patient with persistent asthma, we need to give them preventive therapy. This include inhaled corticosteroid, ICS, as the treatment of choice to reduce the asthma symptoms and prevent asthma associated hospitalization and asthma-related death. Okay, and there are a lot of other drugs that we can use. Okay, next okay, next. Okay, sometimes the patient can come to the doctor with acute exacerbation. So first we need to assess the severity of asthma attack. Then we can plan for appropriate treatment. So in the acute asthma exacerbation, short-acting beta agonist or SABA is the first line treatment. It will be given by MDI SABA via spacer to the patient, as you can see in the picture. And then it also has same efficacy as nebulized SABA and parenteral route is given if the asthma is too severe or life-threatening. Next. So this is the assessment of severity of acute asthma exacerbation in the children. You can see, I hope you can see after this. Yeah, so we can classify the severity into three: mild, moderate, and severe. Mild, moderate, severe, and life-threatening form. Okay, so these are the characteristics of the severity. Okay, next. We can also give the patient oxygen if the patient is acutely distressed. We give it with SABA, especially in severe and life-threatening asthma or partial pressure of oxygen is less than 95%. It can be delivered by nasal prong. Next, we can also give systemic corticosteroids. Is essential to hasten the recovery and should be given early. It can be given oral or intravenously.
I think you all kan yang fokus sangat on management lah your level ni tau.
Sebab
tak tahu
saya
kenapa you nak sebut pasal management sangat. You history pun tak ada sangat. How to identify asthma pun tak ada. Cuma management. Tau, your level ni management ni tak penting tau. Apa nasal prong semua, everything semua, you know, need for you all to know those things tau. IV steroid, everything semua, you know, need for you to know for your 3 level ni. I found out your 3 level kan, dua benda you all selalu fokus unnecessarily tau. Waste time. Sampai 1 jam lecture tapi waste time. Satu, pathophysiology. Nombor 2, management. Management selalu lepas separuh pada lecture notes. Padahal your level is to identify, to recognize the disease. It's more of the history. What history you should take? History of environment, history of contact with pets, history of ni banyak tau. History tak ada lalu. Before you want to learn about this, apa tu, IV steroid ni semua, no, don't waste time on this. For what? This one you boleh baca dalam tu ni je. Forward lagi tengok.
Lagi bawah. So yang bawah ni
IP apa benda filing nak belajar apa you all medicine sulfate apa you nak belajar all those things. Waste time dia. Semua is nothing not related to you all. Tak keluar apa aminophylline, medicinal sulfate dalam exam you all. Management. Year 3 ni, kalau you don't know about management, is okay tau. Because you learn more in year 5. Tapi year 3, you must know about the disease. Forward lagi. Semua management. Stop. Lagi forward. Semua ni you boleh baca dalam tu je. No need. Go back to forward again. Backward. Okay, depan lagi. Forward. Lagi forward. Sini. Ini is the core of you all. Depan lagi. Forward. Backward. Nice. Clinical symptom. Forward. Anda sampai clinical symptoms. Sini. That is the core of you all. Faham? This one, kalau you spend half a lecture pun, I'm okay tau. What history important? The child with asthma. Those with chronic asthma, those with recurrent admission, those with acute exacerbation. That is more important to you all. Lagi, forward. And then for exacerbation, the most important for you all, forward. Forward. Go management. For the most important for you all is acute exacerbation is to ability to assess the severity. Is it mild acute exacerbation?
Saya letak dia dekat management, kat bawah sikit.
Apa management? Forward lagi. The drug therapist lagi.
Bawah sikit and bawah lagi sikit.
Lagi.
Ni
this is the most important for you all. Assessment. This one is part of your history taking and general examinations. What you put in the management? You nak tahu apa? Medicinal sulfate, everything semua, no need for you to know. I don't want to go about the management. No point for you to know about the management so much at the moment. You ada brief apa tu you all should know dalam what is to present in the seminar. I tengok your final year ni, kalau the year ni, sometimes dalam management tu half of the lecture tau. Zul, anything else you want to talk about?
I think the most important thing in asthma is we need to classify the patient according to the severity. This is the severity classification, because in that
You discussed this one lah.
I discussed just briefly just now.
This is the one that you have to discuss in detail. Bukan the medication of medicinal sulfate, bukan medication of ni. This is the one that for your level.
Okay.
Forward lagi tengok. This one tak payah sangat.
Lagi
this one
satu
tak payah.
Lagi satu yang dekat atas, ada dekat atas sikit. Lagi satu, yes, ini. Yang ni evaluate between intermittent and persistent asthma.
Tak payah this one. You nak hafal this one. I pun tak hafal for information.
Okay.
Sebab tu the problem with you all dependent on pediatric protocol. You tak tahu pediatric protocol is not for medical student. Pediatric protocol is for doctors and to manage the patient. Pediatric protocol focus on the management because we want the doctors to manage. It's not a pediatric protocol is not the guideline to you apa nak belajar. It's not for you. Pediatric protocol was not designed for the medical students. Those who read pediatric protocol will fail. It's not because this thing won't come out in your MCQ, this thing won't come out in your exam. This thing will not come out. I think we finish already here. Because you are going to spend 1 hour on asthma, which is waste of time, and whereas each of you should present not more than 25 minutes only. Second presenter.
Okay. Bismillahirrahmanirrahim. Good afternoon, doctor and fellow colleagues. I hope you guys can hear me clearly. I am Nik Anis Afifah binti Abdul Aziz. Today I will talk on bronchiolitis. Next. Okay, this is the outline of my part. We'll start with a brief introduction of bronchiolitis, the background, epidemiology, etiology, and pathogenesis. And then we will focus on the clinical features, which includes the HOPI and the expected physical findings, the differential diagnosis, a little bit on investigation and management, as well as the complication, prognosis, and prophylaxis. Next. Next. Okay, according to CPG of pneumonia and respiratory tract infection in children, viral bronchiolitis is a common respiratory illness, especially in infants between 1 to 6 months old. It is basically a disease of bronchioles. So with inflammation going on, there will be increased mucus production and occasional bronchospasm that sometimes can lead to airway obstruction. It is commonly caused by virus and may incur a life-threatening condition in high-risk infants. Next. Okay, epidemiologically, viral bronchiolitis is the leading cause of hospitalization among infants, which occurs almost exclusively during first 2 years of life and peaks at the age of 2 to 6 months old. The severe respiratory distress is more likely to develop in high-risk infants, namely those who are premature or have underlying chronic lung disease, or the infants at a very young age, which is less than 6 weeks old, and congenital heart disease. The viral bronchiolitis, it occurs in seasonal patterns where in temperate countries or four-season countries, it is reported that the case is on the rise during winter. But in Malaysia, it is endemic throughout the year. It is postulated that it occurs with 2 peaks or 2 spikes, which are in the middle of the year, in June and July, and at the end of the year, in December to January or February. Next. Okay, respiratory syncytial virus, or RSV, remains as the most common causative organism of viral bronchiolitis in Malaysia, which accounts of about 50 to 90% of the total cases. Other viruses include human metapneumovirus, parainfluenza virus, and rarely the bacteria Mycoplasma pneumoniae. Next. Okay, so how do these bugs or this organism cause pathology in the infected patients? Basically, this infection can be contracted upon contact of infected respiratory secretions, be it direct or indirect contact. And once the virus has managed to gain entry into the host, it will infect the terminal bronchiolar epithelial cells and triggers inflammatory responses such as edema, excessive mucus production, bronchospasm, and epithelial lining necrosis, all of which will cause small airway obstruction and atelectasis, or the collapse of the lung or the alveoli. Next. Next slide. Okay. Clinical features. We need to know that bronchiolitis is a clinical diagnosis, so it can be recognized from the clinical signs and symptoms alone. And this flowchart here shows the common history of presenting illness of infants with bronchiolitis in a chronological order. But yeah, of note, the clinical presentation varies from one patient to another, so it does not necessarily follow through the chart in sequence. Okay, once a child is exposed to the virus, to RSV, for example, it will take several days before he or she starts to exhibit the symptoms. They are generally well until 3 to 4 days after the exposure. And the parents may notice that their children is having profuse runny nose or nasal congestion with or without decreased in appetite or poor feeding. And then 1 to 3 days later, cough and fever will start to develop. And in many cases, the patient may develop dyspnea and wheezing too. Parents will come complaining that the baby is having breathing difficulty or noisy breathing, which refers to the wheezing. Other history includes intercostal and subcostal recession, apnea, and signs of dehydration following poor feeding. Next. Okay, during history taking, it is important for us to assess the patient, and yeah, if they checked all the most of the list of risk factors of our provisional or the differential diagnosis that we have in mind. For example, for viral bronchiolitis, we need to ask if there is previous sick contact. Also ask about the natal history, like was the baby born at term, because preterm babies are at high risk of developing, of contracting this infection. And then also ask if there is any congenital heart or lung disease, and if the baby is breastfed or not, because from my reading, breastfeeding serves as the protective factor towards this kind of infection. Apart from that, we also need to ask other history to explore more on the supporting and opposing points of our differential diagnosis. And yeah, these are the examples of questions that we can ask. Next. Okay. For physical examination, on general examination, the infant will present with a sharp dry cough and appear cyanosed or pale, be fever with low fever and tachycardic. And upon inspection, the respiratory rate is usually high. The baby is tachypneic, and there is intercostal recession and subcostal recession noted, just like in the picture. The infant may also present with signs of respiratory distress, such as nasal flaring and grunting. Next. Okay, on palpation, the chest is hyperinflated. This is due to the air that is trapped in the lung. You know, when there is obstruction in the airway, so there is problem in air expulsion. So the air will trap in the lung, and the chest will be hyperinflated. Okay, and then following this, we will also find that the liver is displaced downward, and the sternum is prominent. On percussion, there will be hyperresonance due to the hyperinflation. And on auscultation, we will find reduced air entry, the crepitations, and high pitch wheezes or rhonchi. Next. Okay, this picture just summarizes the clinical features of acute bronchiolitis in infants that we have discussed before. Next. Okay, for investigation, it is not routinely done to confirm the diagnosis. It is rarely helpful, but careful assessment of oxygenation and respiratory status is very important in handling patients with viral bronchiolitis. So we will aim to maintain the oxygen saturation above the 93% as ascertained by pulse oximetry, and the blood gas and chest X-ray is rarely done unless except for in severe cases, for example, if in high risk group or if the patient presents with unusual clinical features. Okay, other than that, nasopharyngeal swabs for respiratory viruses are beneficial for cohorting or grouping the admitted patients. Next. Okay, these are the chest X-ray of infants with bronchiolitis. The common findings are the hyperinflated lungs with flattening diaphragms, and then the horizontal ribs, the increased in hilar bronchial markings, and patchy areas of atelectasis that is shown by the arrows. Next. Differential diagnosis. Okay, actually it is difficult to differentiate this diagnosis due to the common features that they shared. But with good knowledge and careful assessment of the patient, yeah, we can reach the correct diagnosis. These three differential diagnoses can be differentiated based on the age group, the etiology, the risk factors, history, and few examination findings as stated in the table. And yeah, sometimes this disease may overlap, like for example, bronchiolitis may be complicated by secondary bacterial infection, which is pneumonia, and it may also precede the development of asthma later in life. Next. Okay, this is a list of conditions associated with wheezing that we can consider as our differential diagnosis as well. For example, the foreign body, we know that babies, they are playful, so they tend to put everything in their mouth, so they may choke on peanuts or small toys. We need to also consider medical conditions such as cystic fibrosis, congenital area obstructive lesion, and exacerbation of chronic lung disease. Next. Okay, for management, next. Okay, majority of children with viral bronchiolitis has mild illness, and only a small percentage of them is admitted to the hospital. The decision to determine hospitalization in bronchiolitis is essentially clinical, as outlined in the table, and it is also important to consider the distance from house to the hospital and the parental anxiety when evaluating the need to admit the patient in the hospital. Next. Okay, on how to manage the patient, we will focus mainly on the respiratory monitoring, the control of fever, hydration, and oxygen admission if necessary. So for oxygen therapy, we will aim to maintain the oxygen saturation of more than 93% with humidified oxygen delivered via nasal cannulae. Also, yeah, we need to always monitor the signs of impending respiratory or heart failure, such as hypercarbia, the rise of the partial pressure of the carbon dioxide, or if the SpO2 is not maintained. For nutritional and fluid therapy, nasogastric feeding is indicated for patients with feeding problem and to empty the dilated stomach. And IV fluid, intravenous fluid, can be given to patients in respiratory distress, cyanosis, or apnea. Next. Okay, for pharmacotherapy, actually there is no evidence to support the use of bronchodilators in this disease, in viral bronchiolitis. But hypertonic 3% saline solution that is given via nebulizer is thought to be beneficial to increase mucus clearance and
Oh, apa jadi?
Dia terkeluar sekejap. I think she's coming back soon. Sekejap.
Anis, unmute dulu. Unmute.
Dapat lagi?
Okay, sorry. Dapat dah, Doktor. Hi.
Oh, okay.
Okay, sorry. Where am I just now? I think antibiotics, right? Okay. Antibiotics will only be given if we suspect a secondary bacterial infection. Yeah, because we know antibiotics is not effective in treating viral infection such as bronchiolitis. Next. Okay, for the complication in previous slide. Previous slide. Okay, complication is rare except in high-risk infants where they may present with complications such as apnea, respiratory failure, dehydration, asthma, or secondary bacterial infection, which could be the bacterial pneumonia. Next. Okay, for prognosis and prophylaxis, most of the case, the patient will recover within 2 weeks, and most hospitalized children will show marked improvement in 2 to 5 days with supportive treatment alone, which is the fluid therapy and oxygen therapy if needed. For prophylaxis, administration of monoclonal antibody to RSV, which is given monthly via intramuscular injections, is proven to reduce number of admissions in high-risk infants, but it is expensive, so it is only done in hospital settings. Another way to prevent the transmission of this infection, of course, just the common sense, avoid contact with sick people, cover coughs and sneezes, wash hands properly, and do not share the cups or utensils. Next, okay, I guess that is all from me. Shall we proceed, or yeah? Do you guys have any question?
Okay. Any questions? Ada. Next presenter.
Okay, thank you.
Okay, 1 second. Let me present my screen. Second. Okay, boleh nampak? See? Okay, Assalamualaikum. My name is Nur Hassana binti Nuruddin, and today I will be talking about viral croup and epiglottitis. So first off, let's start with viral croup.
Nama. Apa?
Nur Hassana.
Nur Hasanah.
Nur Hassana.
Okay.
Yeah, okay. Okay, so let's start with viral croup. So another name for viral croup, a more scientific name, you can call it, it's called laryngotracheobronchitis. So as the name denotes, it's the inflammation.
You type ke atau you ni?
Sorry,
Cut and paste.
I cut and paste.
You
I
own
type.
site.
Oh, I type.
Kenapa you crowded macam ni?
Oh, I was trying to fit everything in one slide so that we have less
It's
slides.
not good. It's not way to
Okay.
go.
Okay,
Usually
okay.
one definition, satu slide, pathophysiology, one slide, epidemiology,
All
one
right.
slide, ethology, one slide.
Okay, okay. I
Tomorrow
will do that next time.
Your slide.
Right.
Ah,
Okay.
ah.
Okay, Doctor. I will take note. Thank you, Doctor. Okay. Then I can zoom in. Okay.
Tak payahlah. Okay
Tak
lah.
payah. Just to make it easier for you to see. Okay. So it's inflammation of the larynx, the trachea, and the if in severe cases, the bronchi. But normally it affects until the subglottis. So it's the viral inflammation that spreads along your upper respiratory tract. And then viral croup is actually a clinical syndrome, which is characterized by first barking cough, second inspiratory stridor, third hoarseness of voice, and fourth respiratory distress. We will talk more about this later on. Yeah. So for the epidemiology, in Malaysia, it normally occurs it affects from the 6 months, infants and 6 months up to 6 years old, but the peak incidence is at 2 years. The most severe cases occur in children under the age of 3. It affects twice as many boys compared to girls, and then 15% of the patients actually also have a family history of croup. Yeah. And then just to touch briefly on the pathophysiology. So when you have viral infection in that area, so you'll have mucosal inflammation, hyperemia, and then increased secretions in the larynx, trachea, bronchi. So then you have edema of the subglottic area. So when you have edema, this will narrow the trachea, so causing partial obstruction of your airways, which explains for the symptoms later on. Yeah. And then for the causes, viral croup is commonly caused by parainfluenza virus types 1, 2, 3. But as you can see, there are also many other viruses that can cause it, as written here. There are also rare causes of croup, including Mycoplasma pneumonia and Corynebacterium diphtheria. But since the introduction of diphtheria immunization, it has now become a rare cause. So it's mostly just parainfluenza virus now. Yeah. So we move on to the clinical features. So for the symptoms, so in the early phase, the first 12 to 72 hours, certain patients may present with low-grade fever, but the absence of fever does not exclude viral croup. Yeah, and then they also have coryzal symptoms, which include runny nose and sore throat. And then as this progresses, you start to have the harsh stridor. The stridor may be inspiratory, or it may be biphasic. If it's inspiratory, it means that there is collapse of the supraglottic region. And then if it's biphasic, then you already have near total airway obstruction. And then in the early phase, this stridor normally only occurs on agitation, but as it progresses, it can also occur at rest. So stridor, later on, like if you Google by yourself, it actually sounds like, when you turn on the windshield of your car, but there's actually no rain. Yeah, so it makes that sound. Yeah. Okay, so that's one, that's stridor. And then the second one is the barking cough. Now they say that this barking cough sounds like a sea lion. You can also Google that later on, because if I try to include links over here, I'm worried that the audio, there might be problem. So yeah, that's why I didn't do it. Yeah. And then the third one is the hoarseness of voice. I can present with hoarseness of voice because the vocal cords is also in close proximity to the area. And then you can have respiratory distress of varying degrees. So the signs of respiratory distress includes this one, as mentioned, tachypnea, tachycardia. You can also have nasal flaring. And so nasal flaring, I think in the picture given by Zulfakar in the first slide for his asthma, you could see that the nostrils are flared because they're trying hard to breathe. Yeah. And then you also have expiratory grunting. So when this occurs, this is actually a sign of severe respiratory distress. And then head bobbing is actually due to the use of accessory muscles. So accessory muscles include, okay, for inspiration, it includes the scalene muscles near the neck, and then in severe cases also the sternocleidomastoid. And then when they are using the sternomastoid muscles, which is near the neck, so when they breathe, their head also bobs along. Yeah, so that is a sign of severe respiratory distress as well. And then the suprasternal, intercostal, and subcostal recessions, also you could see in the picture given by Zulfikar earlier as well. So when the thing is, when the children, they breathe in, their chest wall is more compliant compared to adults. So when they breathe in, they have more like negative pressure. So it also goes in, you know, all the areas, suprasternal, intercostal, subcostal. The deeper the recessions, the greater the respiratory distress. But one thing that we have to bear in mind is that children, compared to adults, they get tired more easily when they try to breathe hard. So sometimes you might not see this severe, marked recessions, but that does not mean that they are not in severe respiratory distress. Yeah. Okay. So a late sign also can be central cyanosis if they have severe hypoxemia. And then they may present with signs of dehydration if they are unable to eat or drink well due to this. And then upon auscultation, you will hear reduced breath sounds and overt inspiratory stridor, like the ones that I have explained earlier on. In some cases, there may also be mild wheezing. Yeah. And then for investigations, croup is actually diagnosed based on clinical grounds. So that's why you have to familiarize yourself with the signs and symptoms, because normally that would be enough to diagnose it if they present typically as what I presented earlier. And then the first thing that we have to do is actually airway management. Airway management is more important. And then later on, after that, you can proceed with the investigations. However, like the ones mentioned here, however, you can do laryngoscopy if you, this is in order to rule out other more life-threatening conditions, you can say, like for example, acute epiglottitis, retropharyngeal abscess, or peritonsillar abscess. Sorry, oh tak buat dah. Oh,
Tak
okay.
pernah buat.
Oh, tak pernah buat. I
I
see.
have treated hundreds of croups, tak pernah buat laryngoscopy.
I see. So you can just differentiate based on the sign and symptoms. Okay. All right.
I'm not there to do laryngoscopy. You suspect epiglottitis.
Sorry, dah tak buat dah, is it?
I'm not there to do laryngoscopy.
Oh.
I suspect acute epiglottitis.
Oh, okay. All right then. Well, okay. And okay, so apart from the clinical diagnosis, later on, okay, blood investigations, it's very non-specific. You just see lymphocytosis, raised ESR. And if, just for knowledge, if you do neck radiography, anteroposterior view, you can see the steeple sign, which is diagnostic for croup. Yeah. So steeple sign is over here in this picture. So you see that inverted V sign. So that shows the narrowing caused by croup. Yeah. And then, okay, PCR, fluorescent antibodies, it's not essential, but just for isolating the virus, but it's not not useful at all for a diagnosis or management. Yeah. So it's based on just clinical symptoms. Yeah. And then this one is how you assess the severity for the croup. Wegener. There's also another system that I found. They use Wesley scoring, but I think in Malaysia, I think they use this one, this Wegener classification. So it classifies according to mild, moderate, and severe croup. So basically, the difference is that, okay, I'll just compare along the three. So for mild, remember, as I mentioned earlier, stridor, like maybe in the early phase, it only occurs when the child is agitated. But as it progresses, then the stridor can even occur at rest. Yeah. And then in mild, there's no respiratory distress yet. Moderate, you see mild degree, and severe is a severe respiratory distress where you see marked recessions. Yeah. And then for mild and moderate, there is no altered consciousness yet, but in severe, you might start to see some altered consciousness. Yeah. Pulse oximetry can be helpful if you want to assess the oxygen saturation. So if the oxygen saturation is less than 93%, it's considered severe. ABG is not helpful because it may only be abnormal at the late stage. Plus, it's distressing for the child at the moment because you need to take blood, so you don't really need to do it. Yeah. And then as for the management, okay, just as an overview, I will not go into it. You only treat inpatient for moderate and severe cases, and then they treat this using steroids, nebulized adrenaline, and oxygen therapy being treated. No. So I'll just, but basically, they just use those three. Yeah. So going to the differential diagnosis, I think this one is more important. So there are also other conditions that can mimic croup. So as from this diagram over here, so the conditions that can also present with stridor, so we have spasmodic croup, bacterial tracheitis. Foreign body aspiration must always be kept in mind if a child presents with stridor, and then also epiglottitis, and then another one which is not in this picture, diphtheria, although it is rare now due to the presence of vaccines, but it's should still be in the back of your mind. Yeah. And then also retro or peripharyngeal abscess. So I will have like another slides on epiglottitis later on. But okay, so like for example, for the foreign body aspiration, you need to ask about any history of choking or the patient also has dysphagia. And then, okay, let's talk about the recurrent croup, the spasmodic croup first. So this is actually a quite common upper respiratory tract obstruction. It may follow
spasmodic
rare. Okay. Okay, it may.
Yes.
It may. Okay. It's less common compared to croup. Okay. This one, the etiology is more of due to allergies. So if you have hyperreactive upper airway, and then for the clinical features, it's similar to croup, but then they don't present with the preceding fever and coryzal symptoms. Yeah, and then the complications, they can present with the atopic diseases like your allergies, like your asthma, rhinitis, and eczema. And then as for bacterial tracheitis, this one is also rare, but if it occurs, it's a very dangerous complication following viral croup. Some of the causes are due to MRSA Staph aureus, but the difference between this bacterial tracheitis and viral croup is that this one, they present with high-grade fever, and then the child will appear toxic looking. Okay, I'll explain about this later on in epiglottitis. Yeah, and then the thing is why it's dangerous, because in bacterial tracheitis, the airway obstruction is even more rapidly progressive compared to the viral croup. And then when you do the tracheal incubation, you can see copious thick secretions. That is what actually causes the pseudo membrane looking appearance. Yeah. And then over here, okay, if the patient also has high fever or sore throat, limited neck movements, then as you can also suspect retro or peripharyngeal abscess. Yeah. So that is for croup. Now we go to acute epiglottitis. So the reason why we have to be able to differentiate between acute epiglottitis and croup is that, well, first, they do have overlapping clinical features, but in epiglottitis, it's even more rapidly progressive, and then to become totally, for the airway to become totally obstructed. Yeah, and then in epiglottitis, it's a life-threatening condition. So that's why it's important for you to detect it early so that you can manage it early. Yeah. So, okay, we go to the introduction. So as the name denotes, It is the acute inflammation of the epiglottis, but also surrounding structures like the area epiglottic fold and arytenoid soft tissue. That is surrounding the epiglottis. But after the introduction of Haemophilus influenza B immunization, we now have 99% decreased in incidence of epiglottitis. Yeah, and it affects all age groups, but it's most commonest in 1 to 6 years old. Yeah, and then for the causes, mostly due to Haemophilus influenza type B in unimmunized patients, but there are also other causes as mentioned over there. So, so over here, you can see that's the structure of the epiglottis. You can see I'm zooming in over there. Okay, so that is the one affected. Okay, so just touching briefly on the pathophysiology. When the infective agents, they invade the epiglottis, causing inflammation. And then you have edema of the epiglottis and also its surrounding structures, which causes the airway obstruction. One thing to take note is that the epiglottis in a child is different from epiglottis in adults. In children, so epiglottis is actually cartilage. And then in children, it's more pliable compared to adults. Pliable means it's more easily bendable, you can say. So when you have edema of the epiglottis, you imagine you have edema of the epiglottis, and then this increases the weight and the mass of epiglottis. It becomes easier for it to be pulled down and more bended down due to the edema. And then if you recall, the function of epiglottis is to cover the laryngeal inlet so that the food and your liquids does not enter your trachea. Yeah, so if you have edema of that, you will have obstruction of the airway. So that is how it is very dangerous, because this can lead to asphyxia, which is suffocation, and also respiratory arrest if not there's no early intervention. Yeah. Okay, so for the symptoms, compared to viral croup, the epiglottitis, they have very acute onset, like within hours. And then they present with high-grade fever compared to low-grade fever in viral croup earlier. Epiglottis, it's more common they have high-grade fever, and they also have sore throat. And then one symptom that is specific and sensitive for epiglottitis is the drooling of saliva, because it's actually difficult for them to swallow. So they start drooling, yeah. And then they may also present with soft stridor. Compared to croup earlier had harsh stridor. Yeah, this one is supposedly more softer. And then they can also have shortness of breath. And then they have minimal cough in epiglottitis compared to the barking cough in croup earlier. Yeah. And then as for the signs, you'll see that the child is ill and toxic looking. So toxic looking means they may appear pale, cyanotic, lethargic, or very irritable. Yeah. And then they will assume this tripod position. So this tripod position is the one that I'm showing in this picture over here. So if you see, the child is sitting upright, and then the arms are like on the knees, and then they're leaning forward. The mouth is open. They have the chin up. Sometimes, in some cases, the neck may even be hyperextended. This is all because they're trying to make it easier for them to breathe. So this is the tripod position. Yeah, recognize this. Drooling, like I mentioned earlier. And then if they try to speak, it's actually if the child has epiglottitis, they are very reluctant to speak. But when they do, you can hear muffled voice. So muffled voice is, or otherwise known as hot potato voice. It's like when you try to eat something hot, when you're trying to eat hot food and then you talk. So that's what it sounds like. Yeah, hot potato voice. It's there is nothing very clear coming out. Yeah. And then sometimes you may also have cervical adenopathy, respiratory distress, as I've elaborated earlier, and then stridor. Soft stridor is a late sign of epiglottitis. Yeah. An important thing to note is that you must not try to directly inspect the throat, because this can lead to respiratory arrest. So make sure you have the necessary equipment if you do have to examine the throat. Yeah. So just like viral croup, epiglottitis is also a clinical diagnosis. As doctor mentioned earlier, laryngoscopy is now not commonly done, but if you do it, you have to do it in a controlled environment. And then what it shows is the cherry red intense swelling of the epiglottis and the surrounding tissues. And then for lateral neck radiography, you can see the thumb sign over here. The one on the left is the epiglottitis. So normal epiglottis, it should just be like a thin like projection coming out. But then in the left one, you can see the swelling already. So that is what you call the thumb sign. This is just management. You can skip. Okay, so this is just comparison between the two. I think you can read this on your own because it's very straightforward. But basically you just have to be able to differentiate between viral croup and acute epiglottitis, because in the case of epiglottitis, the patient can have very rapid deterioration. Yeah, and then comparing all the signs and symptoms earlier,
Kenapa? Hasanah?
Doctor, she's trying to reconnect. Wait a second, yeah.
can everyone hear me?
Yes, Anna.
Yes.
Yes.
Okay. Sorry, I think I got cut off at the comparison. Yeah.
Yes.
Okay, but actually I'm already almost done. I just wanted to say you can actually read the comparison table on your own because it's very direct. It's very straightforward, and basically know how to differentiate between epiglottitis and viral croup, because in the case of epiglottitis, the patient can deteriorate very rapidly, and the most specific and sensitive sign or symptom for epiglottitis will be the drooling. Meanwhile, for viral croup is the severe barking cough. So yes, that is all from me today. Thank you. Thank you very much.
Any questions? You all dekat mana sebenarnya semua ni? You all ni?
Dekat Mahalah.
Malah. Internet problem.
The quarantine. Yeah.
Bila habis quarantine?
Khamis ni, insyaAllah.
Next presenter. Siapa next presenter?
Me. I will share the slide first. Me, Zafira.
Topik siapa?
Can you see the slide?
Zafira.
Childhood pneumonia. Yes.
Okay.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So my name is Nuzafra Aida binti Ahmad Al-Kushari. So today I'll be presenting regarding the childhood pneumonia. So basically this is the contents of my presentation for today. Okay, firstly, I'll be explaining the overview and epidemiology of the childhood pneumonia. So for the definition, pneumonia can be defined as an infection of the lower respiratory tract, can be caused by virus or bacteria or also fungus. And it involves the airways and also parenchyma of the lung with consolidation of the alveolar spaces. For the etiological agents in childhood pneumonia, it is vary with age. So for viruses, it is more common in younger children, while for bacteria, it is the next regarding the classification of the childhood pneumonia. We can classify the pneumonia based on the anatomical, which is the lobar and also bronchopneumonia, and the etiology, which are the community acquired, nosocomial and also aspiration pneumonia. So for the epidemiology of pneumonia, the incidence of pneumonia in childhood peaks in infancy and is relatively high in childhood. So according to WHO, this pneumonia known as the single largest infectious causes of death in children worldwide. And annually, up to 5 million deaths due to pneumonia have been reported among children less than 5 years old in the developing nation. While in Malaysia, the prevalence of pneumonia in children less than 5 years old is estimated to be 28 to 39.3%. So next, we move on to the risk factors of childhood pneumonia. So here are the list of risk factors for the children who can be prone to get pneumonia. So if they are low weight for age, lack of breastfeeding, failure to complete immunization, this will reduce the immune system and they tend to have the pneumonia. Other than that, coughing siblings at home, overcrowding bedroom also increase risk of getting childhood pneumonia. Cigarette smokes, especially among the parents, because this may start the defense mechanism in the lung of the child itself. Other than that, congenital or acquired immunodeficiency disorders, congenital heart disease, bronchopulmonary dysplasia, cystic fibrosis, asthma, all these can increase the risk of getting childhood pneumonia. We have also sickle cell disease, neuromuscular disorder, gastroesophageal reflux, and also tracheoesophageal fistula. So next is regarding the etiology and also pathogenesis of childhood pneumonia. So for the etiological agents, as have been mentioned before, it is vary with age, and in clinical settings, it is often difficult to distinguish between viral from bacterial causes of pneumonia. So in the case of bacterial pathogens, we can classify it according to age group of the children. So for the newborns, the common bacterial pathogens that may infect them are group B streptococcus, E. coli, Klebsiella species, and also Enterobacteriaceae. In infants, we have Chlamydia trachomatis. So for preschool children, the common bacterial pathogen are Streptococcus pneumonia, Haemophilus influenza type B, and Staph aureus. And less common, the group A Streptococcus, Moraxilla catarrhalis, and Pseudomonas aeruginosa also can infect the preschool age group. And the last one is the school age group, which can be infected with Mycoplasma pneumonia and also Chlamydia pneumonia. And the next one is viral pathogens. So we have a respiratory syncytial virus, which is RSV. It is known as the common cause of viral pneumonia, especially in children less than 1 year old. We also have parainfluenza virus, type 1, type 2, and also type 3. This is also a common cause of acute respiratory infection in infant and also children. And also it can cause lower respiratory tract disease, especially in younger children and also immunocompromised patients. Other than that, we have influenza virus, also adenovirus. So regarding the pathogenesis of pneumonia, firstly, the infected patient must be exposed to the pathogen. There are several ways for the pathogen to enter our respiratory tract system. It is due to the inhalation, which is directly get from the infected patient, from the aspiration, also hematogenous. And once they infect, it also depends on the host factors and also virulent pathogen. The immunization, it may increase the risk of getting increase the risk of pathogen to infect the respiratory tract. And other than that, if they are present with cystic fibrosis or asthma, it is also increase the risk of patient of getting pneumonia. So once the pathogen get enter into our respiratory tract system to proliferate, and this is when the inflammatory response being initiated to fight the infection. So there are both local inflammatory response and systemic inflammatory response will be initiated, where the local inflammatory response, it involves the recruitment of the white blood cell, such as lymphocytes, monocytes, also neutrophils to the infection site. While for the systemic inflammatory response, when the cytokine reach the systemic circulation. So when both this is responsible for the development of signs and symptoms of pneumonia, which I will explain after this. So next, regarding the clinical features of pneumonia in children. So as we know, history taking is important of making diagnosis in any kind of disease. So the first thing in the history of illness, if our patient is a neonate, they usually present with poor feeding and also irritability. So we can ask we can ask the parents or the caregivers whether the child refuse to being breastfeed or it decrease the intake of breastfeeding. And also for irritability, we may ask whether the child always crying or not. So there are a few symptoms of pneumonia, which is a non-specific. For example, the cough, runny nose, and presence of fever. So for the cough, we may ask whether the patient produce sputum together with the cough, because it is likely to be bacterial causes. Other than that, we can ask whether there is presence of fever, because in the case of bacterial pneumonia, usually they have fever, while for viral causes, they always low-grade fever, and sometimes there is no fever at all. And other than that, lethargy, headache, this is common in older children, and noisy breathing. So noisy breathing, we may ask the parents or the caregivers whether they notice any abnormal noise comes from the children. Next is regarding the chest pain and abdominal pain. This is due to pleural inflammation and common in older children. And shortness of breath or difficulty to breathe. This is a common symptoms in child who have pneumonia. In the case of shortness of breath, we may if they are infants or neonates, we can see whether they are use of there are chest indrawing in the patient while they are trying to breathe. And also, if older children, we can ask whether they tend when they are shortness of breath during doing activity. And other than that, we have also diarrhea vomiting, which is an atypical symptoms in pneumonia, and it is common in older children. So for the past medical history, we may ask the patient whether they have asthma or cystic that have been mentioned before, because all this condition can increase the risk of patient getting pneumonia. So we need to ask the patient whether they have this disease or not. So other than that, we can ask family history, whether there is any siblings with the same symptoms at home, because some of the virus we can get it from the cough or sneeze from the other person. So if there is any infected siblings at home, they might get from them. So also asthma also important to us in the family history, because it is run. And the next one regarding the travel or contact history. So we need to ask any contact with infected patient or any travel history to any endemic country, because all those symptoms in the HOPI, it is not specific for this pneumonia. So it can be also due to other causes of respiratory disease. So for the immunization status, we can ask whether they have complete or incomplete their immunization. However, still it does not eliminate the risk of having pneumonia. And in the social history of the patient, we can ask whether the parents are smoking or not, because as we know, smoking can increase the risk of getting pneumonia because it impair the defense mechanism in the lungs. And either we can ask, does the parents send their child to the school or daycare center, because this is an area which overcrowded can easily get infected from person. And the last one is regarding house condition. Either it is overcrowded with people or not. So this is like a summary of symptoms that may present in patient with pneumonia. For example, fever, cough, breathlessness, rapid and shallow breathing, runny nose, lethargy, poor feeding, especially in neonates, restless, agitated, irritated. And the last one is pleural inflammation that may present with pleuritic chest pain, neck stiffness, and also abdominal pain. So during physical examination, firstly, we check the respiratory rate of the patient, because tachypnea is one of the commonest signs in patient with pneumonia. So tachypnea, we have the list of the range of when the patient is tachypneic. For example, in neonates, if it's more than 60 breaths per minute, so it shows that the patient is tachypneic. Other than nasal flaring, as you can see from the picture, the nasal flaring is when it's widen the nostril. So when it is widened, it shows that the patient is in respiratory distress. Air hunger, toxic looking. These are also the signs of respiratory distress in children. Cyanosis because of hypoxia, grunting, and recession. The use of intercostal, subcostal, supraclavicular indrawing, muscle indrawing. So during palpation, we can see whether there is a decrease in chest movement, especially at the affected site, and also increased tactile parameters. This is mainly due to the pleural effusion. So next, during percussion, we may found the dull to percussion. This is due to the pleural effusion itself. And during auscultation, there may be decreased breath sound, presence of bronchial breath sound, cause crepitations, and also pleural rub. The next one is assessment of severity. So this is important to help us how to manage the patient, the children with pneumonia. So for a patient with the age of less than 2 months, we can classify them into severe pneumonia if we observe that there is severe chest indrawing in the patient and also tachypnea. And in order to classify them under very severe pneumonia, the patient must be don't want to be fit, have convulsion, and abnormally feeling asleep and hard to wake, and there may presence of fever or hypothermia. So in the case for children with 2 months to 5 years age, in the case of mild pneumonia, the patient only present with tachypnea. But in the case of severe pneumonia, there is chest indrawing. So for very severe pneumonia, this classification goes if the patient are unable to drink, have drowsiness, convulsion, also malnutrition. So next, how we want to classify that this patient is tachypneic or not. So as you can see from the table, if we need to know how old the children, how old the patient is, because less than 2 months age, the tachypneic if the patient have more than 60 breaths per minute, and for the 2 to 12 months of age, there is more than 50 breaths per minute, and also for the 12 months to 5 years of age, the respiratory rate should be more than 40 per minute to classify them as a tachypneic patient. So next, we move on to the investigation. So the first one is we do blood test. So the first is full blood count, where we look at the white blood cell count. So if the patient has been infected with virus, usually the white blood cell count is normal or only mildly elevated, and predominance is lymphocyte. While for bacteria, there is white blood count with the predominantly neutrophils. Next is we can do blood culture and sensitivity, which is this is a test, the non-invasive but gold standard test, in order to determine the etiology of the pneumonia. However, there is low sensitivity for the blood culture and sensitivity because it shows only 10 to 30% that there have positive etiology. And this blood culture and sensitivity should be done in severe pneumonia and also patient who is fully responds to the first line antibiotics. Next, we can also do the chest radiograph. This may indicate when the clinical criteria suggest pneumonia, and we may found that there is lobar consolidation or widespread bronchopneumonia. As you can see from the picture, there is a right upper lobe consolidation in the picture. However, this chest radiograph is not always indicated if there is a patient with mild pneumonia. Other than that, we can also do serological tests in patient with suspected atypical pneumonia. So for yes. Okay, so for the acute phase serum titer, more than 1 to 160, or paired serum samples that taken 2 to 4 weeks apart, which shows fourfold, right? This may indicate infection by the Mycoplasma pneumoniae. And the serological test only considered in patient age 5 years and older. And next, we can also do pulse oximetry. This is important for the assessment for oxygenation and also helpful to indicate the severity of pneumonia. And the last one is pleural fluid in case of significant pleural effusion. So this is the complications of childhood pneumonia. There are parapneumonia, emphysema, septicemia, and also lung abscess. So parapneumonia effusion, this is due to accumulation of exudative pleural fluid and if the fluid is grossly purulent, it is known as emphysema. So next for the management. So this is the criteria for patients who need hospitalization, especially in children aged 3 months and below regarding any severity of pneumonia they have. Patient with fever, fast breathing, associated systemic manifestation, those failed with previous antibiotic therapy, those have recurring pneumonia and also severe underlying disorder. So this criteria may help either the patient need to be admitted or not. So this is the inpatient management where we can give an antibiotic. So this is the list of antibiotics that we can give in patient with pneumonia. And the second line antibiotics we can consider when there is no signs of recovery by using the first line antibiotics or the patient remain toxic and ill with spiking temperature for 48 to 72 hours. And for parenteral antibiotics, we may consider in patients with severe community-acquired pneumonia. So other than that, we can also give supportive treatment such as fluids, oxygen, temperature control, chest physiotherapy, and also cough. However, cough medication is not recommended because it will suppress the cough. Children with mild pneumonia, usually we will just give them oral antibiotics. As you can see in the table, the antimicrobial agent that can be used for the certain pathogen. And other than that, we can educate the parents or the caregivers in order how to manage fever, how to prevent, and also to identify signs of deterioration if present in their children. And the child need to be written in 2 days for their assessment or earlier in case of the condition of the child getting worse. Do you have any question?
Okay, it's a bit about the comment. The pneumonia ni you can divide few things. One is anatomy. One is structure, which is pneumonia due like bronchopneumonia, lobar pneumonia, lepas tu interstitial pneumonia, and then second by the cause. Cause is mean that by is it viral pneumonia, bacterial pneumonia, or is it by the aspiration pneumonia, chemical. So that is one thing. Third thing is the age tak payah sangat lah. The two things, the main thing is the type and then the causality. Viral pneumonia, how the presentation little bit, yeah. Bacterial pneumonia, how the presentation going to be. Aspiration pneumonia, maybe I mean sometimes caused by fungal also cause pneumonia, cannon-like lesions, and then that's the thing that you have to remember, not just pneumonia alone, because the diagnosis is lobar pneumonia, let's say it's bronchopneumonia, atypical pneumonia, the diagnosis are like that, depend on the causality. Okay, any other questions? Ada lagi tak?
Tak ada, saya last. Tak ada dah habis.
Habis.
Saya last
Okay.
presenter.
Next, tanya lagi kan? Okay. So next, we will give template next time. The presentation is more focused on clinical for you all. Don't focus on the management. We not expect you all to know the management so much in that year. Because how you to manage things if you not recognize the disease properly. Okay, finish.
Thank you, Doctor.
Okay.
Thank you, Doctor.
Thank you, Doctor.
Presenters.
Thank you, Doctor.
Thank you, Doctor.
Live lah manjur.